Welcome, everyone. My name is Dr. Aisha Delaney-Brumsey. I'm the Director of Community-Based Services with New York City Health and Hospitals. I'm really excited to be here today with you all and also to be hosting episode number 223 on North Carolina's 9-8 and Pure Warmline integration. We have Kelly Crosbie, who's the Director of the Division of Mental Health and Developmental Disabilities and Substance Use Disorders with the state of North Carolina, and her team to talk with us about that today. Just a few reminders, as always, if you can stay mute unless you are speaking. Also, it's better if you use the speaker view instead of the gallery view to see the format for this meeting. And then if you've been here before, you know this, it's a lively chat. Send your questions in, send your comments in. If there's time, I'll take questions from the audience in the chat as well. And there is a new ASL feature. If you want to see the interpreters directly on your screen, you should be able to find that on your More button. Click on that and activate that option. Okay. And since the Crisis Jam started in 2020, we've had nearly 600 unique speakers across the past, I believe it's 5 seasons of this jam. And today we actually have 4 people speaking today. I believe it's 4 who have never spoken before. So welcome as presenters on Crisis Jam. And always looking for additional suggestions as well. So please send those in. The talk.crisisnow.com website is the first place to go if you'd like to look for any previous episodes, you want resources, news, links to some of the resources that we have here. So this is a fantastic resource to just keep in your back pocket and to share with your colleagues as well. This is where you register for the Crisis Jam. So we do require that you register ahead of time for the Zoom. So make sure you are registered. If you do have difficulty with that registration, we also live stream this on YouTube as well. Although we encourage people to come here so you can be part of the conversation. And as I mentioned, here you can see the previous resources, the previous episodes, as well as various news and other resources that you might want to use. There's 2 YouTube channels associated with this, so definitely like, subscribe, follow those. But it's a great way to go back and see some of the episodes you might have missed or revisit with some of the episodes that really spoke to you and that you want to get even more out of. All right. The debate format is one that we've really been leaning into in season 5, and we do have an upcoming debate, or excuse me, this was the previous debate on should crisis facilities require parents to stay during a crisis episode. And the results of this debate were really some of the closest, maybe the closest that we've seen so far. So no was the most common response, 30%, but right behind that, 28% of people said yes. So recognizing that it can be very helpful if parents can stay, but also recognizing that there's some challenges and barriers to that as well. So people are really split, and there's a chunk of people who still were unsure or not decided. So a really great debate, a topic that raises a lot, and 2 great debaters on that. So go back and visit with that episode as well. And this is one that we have coming soon with Dr. Jessica Pollard and David Covington, who we all know they're going to be debating coordinating follow-up care in crisis services requires high-tech software solutions. So that's coming up next month, July 23rd. We also have one coming up on August 27th about whether states should really prioritize building the capacity in the 3 core crisis services or focus one more a broader set of services that supports crisis that would that would include the 3 core services, but are also broader as well. So that's coming up on August 27th. And then coming soon, starting in September, we have season 6 of Crisis Jam Unplugged, Really going to be focusing, of course, on those debates, the live and on the ground episodes, but also leaning into a few topics like substance use, international, making sure we're doing more engagement. So if you have suggestions for topics, reach out with those. Please do reach out with those. I think we've all heard the news that SAMHSA will be removing the third option here for the LGBTQ um, portion of the crisis line. I believe we're able to actually play the intro to that.
Reached the 988 Suicide and Crisis Lifeline.
Para español, marque el número 2.
If you are a veteran or service member or are calling about one, press 1. To connect to support for LGBTQI+ youth and young adults, press 3. Otherwise, to talk with a counselor, stay on the line or press 0. To improve 988, your call may be monitored and recorded.
And so here you can see the statement that SAMHSA released on June 17th explaining the fact that they're removing that option, and that it was part of a pilot program that they worked on with the Trevor Project was the vendor for that. There's also a link, or this is on the Trevor Project's press website, focusing on that order. So go ahead and if you haven't read about that, take a look and get some more information there. So now we've actually gotten to one of my favorite parts of the show, which is the Crisis Jam. And today we are all in the Crisis Jam Showdown. We're all going to be answering this. So put your thinking caps on. So the first question is, which of the following was the earliest peer supports innovator? The peer movement's roots can be traced back to many pioneers. One of the earliest hired those with lived experience because they were, quote unquote, disposed to kindness. You should see a survey pop up on your screen so you can participate. Was that A, Bill Wilson, who was famous for founding AA, Jean-Baptiste Poussin, who was a hospital administrator in France, Clifford Beers, an innovator with Mental Health America, or Jean Fondrain, also a hospital administrator with the Netherlands. So go ahead and select which one you think was the innovator here. And we'll see how we do. I also, for those of you who speak French, I am certain that I butchered Mr. Jean-Baptiste's last name. I have the worst French pronunciation on the planet. So apologies to your ears. Okay. And we'll see how we did as those responses roll in. I thought this one was a particularly tough one, honestly. So we have 41% for Bill Wilson, followed by Jean Baptiste. And let's see how we did as an audience. So fantastic. Not Bill Wilson, but Jean Baptiste was the answer for this. In 18th century France, Poussin and former patient and chief physician Philippe Pinel teamed up to revolutionize care, removing restraints and ending routine abuse at Bicêtre Hospital. So he was a true peer support pioneer. This was a tough one, guys. So congratulations to all of you who did get it correct, and congratulations to all of us for learning something. So next, I will go ahead and pass the mic over to our featured speaker, Kelly Crosbie, and her team in North Carolina to talk to us about the integration of 988 and the Peer Warmline. Kelly.
Hello, everyone. And I hope you can hear me. And I'm going to say thank you to Lisa DeChantis, who I think many of you know. She's presented here before. And I'm going to apologize if I lose my connection because I did something wrong when I registered to join. So I'm on Lisa's account and her computer. So I appreciate her generosity, but we'll see if it keeps working. So it is a real pleasure to be here today. And And as Aisha said, we are one of those agencies that has mental health, substance use treatment, prevention, and recovery, as well as policy services and supports for people with intellectual and developmental disabilities, traumatic brain injury, and problem gambling within our big mega agency. You'll meet others here from North Carolina today. You may know them already. I'm really grateful to be joined from folks from our 988 and our peer Warmline, and my awesome team, Lisa and Brittany, who I know that you know, and they are rock stars, and I appreciate them very much. So, as a pleasure too, he's probably on now, but Rob Robinson is here. He has one of our largest behavioral health managed care plans here in the state of North Carolina. He's also a public entity, which is really cool. So he is our partner for federal dollars and state dollars. And it's really cool that they're a local state entity. So I'm excited that we've got this wonderful group of folks here in North Carolina that really help make the crisis team work. So as you can see, we obviously align really well with the Crisis Now model. And I think probably what's unique about ours is our peer Warmline, which we're going to talk about today, our Somethings line, which is our teen mentoring line. I think people know Somethings is a national program, but we use that as a supplement and a complement and sort of a bridge off of 988. Um, we Other things we won't spend a lot of time talking on because I'm trying to be mindful of our time. But obviously, we are working on a complement of someone to respond in a safe place for help. I do want to point out that peer respites are an important safe place for help here in North Carolina. By the end of the year, we'll have 3. So we're really excited about those. But the last thing I want to point out is that bottom box where we're building a lot off of our 988 line. I think most of you have the same experience as us. So I'm speaking to folks who know, but 988 has had such tremendous success and value here to North Carolina. It has opened many doors, many conversations. We can talk about mental health more freely. Vast majority of people you'll see from our data, and I think it's your experience too, they're not calling in crisis. It has been really a life-saving entry point into the system. And probably like your systems, our system is incredibly confusing. And we live in a culture that's stigma laden. So there's so many barriers to care, and 988 has really helped us, bridge many of those barriers. So we are trying to build more things off of 988, not only our peer Warmline, but also we're going to be launching mobile crisis deployment and tracking in the eastern part of our state that will go off of 988. And we're looking at other options like telehealth and making sure that 988 is able to refer people to a network of next day services. We just consider 988 a tremendous tool. But today I'm here to talk about 988 and why we also complemented it with our peer Warmline and the amazingness that is our peer Warmline. So on the next slide, I think I just have a little bit of information because good news is hard to come by of late, but we had great news in fiscal year 24. We signed on for Medicaid expansion here in North Carolina, and our governor asked the General Assembly to invest a lot of the sign-in bonus in our mental health system in particular. And we were granted $99 million to beef up our crisis system. So this is just an example of some of our investments, and it's across the continuum. Someone to contact, someone to respond in a safe place for help. So these are just some of the investments that we made across that continuum, inclusive of things like non-law enforcement transportation, a pilot that we hope starts here by the end of the year. But that's a celebration for us. And, last year and this year, really, we worked on building an additional crisis capacity within the state. And this year and next year is really going to focus on quality in the system. So making sure we have more uniformity, quality in the system. All of our crisis centers can respond to overdoses, for example. They're all open 24/7. People can have the same experience of care. We've invested money in improving the quality and condition of the facilities themselves, where we're talking about crisis facilities. So it's that, but it's also the financing. And one of the things that Rob, I'm sure, will speak to is one of the longtime leaders in the crisis infrastructure here in North Carolina, the incredible challenge we have, like you all do, with financing the system. So figuring out a sustainable financial model, as well as improving the quality and the experience for consumers when they use the system. That's a real focus for us this and next year. So next slide. So let's talk about the peer Warmline N988 for us. So uh, I am trying to remember what my next slide is after we go to someone to contact. So this is just some of the data that we want to share about our 988 line that led us to work on a complementary peer warm line. So we have a wonderful representative here from Real Crisis who manages 988 for the entire state of North Carolina. They have been our crisis response line forever, and they are a superlative partner. Um, their call volume is high. You're going to see a dashboard in a moment. It continues to grow, and they just do extraordinary work. We did notice some trends though, right? And we're like you, we responded to trends. There were certain groups not calling, certain counties not calling, and we adjusted our marketing and approach just to make sure the word was getting out to everyone in ways that made sense to them. But we found that a lot of our folks were calling purely for support needs, uh, meaning referrals to services, just to chat, and so because of that, we're really using 988 to build additional services, but that's not the point of today. We also noticed that 40% of callers are repeat callers. So again, you may notice the same thing in your state, but to us that said, people need a consistent place to call where they feel safe, anonymous if necessary. They feel like they're getting good care and trust. And that speaks volumes for the wonderful folks who work at our 988 call center, that people trust them and are calling back. But we wanted to be able to address that particular need for folks that are just calling for ongoing support. And we are for all the same reasons that you are. And I have personal reasons about the impact of peers on my own family, and all the research that peers are truly extraordinary. And in North Carolina, we are very blessed with really strong peer organizations, Promise Resource Network being one of them, and Noah's here with us today. So this was just the perfect environment and opportunity for us to work with PRN, who had a local in a county peer warm line that was having tremendous results, tremendous interest. It was a wonderful opportunity for us to really capitalize on that, looking at this trend of people looking for a place where they could consistently call, just to launch it statewide. So on the next slide is just our dashboard. We do publish a public dashboard on 988, just so folks see the trend in callers. And we've seen, there's just a lot of data here, and I told you the most important parts that deal with the peer warm line. But again, some of our advancements are truly based on the fact that our number one user of 988 now in North Carolina are 12 to 19-year-olds, which is good and scary at the same time, which led us to work on some things. But it also speaks to, I think, the strength of our marketing campaign, but also the need here in North Carolina. But again, speaking just to the peer warm line, seeing how folks are just calling for continued support, interpersonal issues, needing a trusted place to call routinely, we really wanted to lean into the peer warm line. So on the next slide was just some information about our peer warm line launch. I know Noah's in that picture. I know you all know Shireen Carico. They're wonderful staff there from Promise Resource Network, and Lisa's there, and it was just a joyous day. We did have a competitive bidding process, of course, just to be clear. We do what we're supposed to do at the state and federal level. But Promise Resource Network was obviously won the bid. They already had a robust line there in Mecklenburg County, which is a big county here in North Carolina. It's where Charlotte, North Carolina is, if you don't know. We're there outside of their respite there in Mecklenburg County. And it was a joyous day. And the peer warm line launched February of 2024. So we have gone past the 1-year anniversary. And the thing that's really important today is to understand that one of the things we think that, besides the peer warm line just being wonderful, is truly the unique and wonderful relationship between 988 and the peer warm line. From the beginning, these were two phenomenal partners who, from the get-go, worked as partners. This was not a competition, never was a competition. And so we try to have a no wrong door approach. People can call whatever line they want to. We advertise both heavily. In fact, we'll be advertising the peer warm line even more heavily this year. But they have a wonderful process for handoffs. They suggest the other line to folks if they need to, but it's a real collaborative partnership. They meet together to problem solve and figure out things when they see trends. But it's such an incredible partnership. And what you'll see on the next slide um, is, um, uh, well, let me go on one more slide. Sorry, I got ahead of myself. But what you'll see on the next line is our dashboard for the Pure Warmline. So if we can go to the next slide. And I wanted to jump to this because there's been an overwhelming response to both 988 and the Pure Warmline. And what we saw with the addition of the Pure Warmline was not any sort of decrease in 988, not at all. We saw a continued growth of 988 use and a continued growth of Pure Warmline use. It's been absolutely extraordinary. North Carolinians need and want the line. And of course, if you go back one slide, this just emphasizes some of the collaboration points between both. We worked very hard to have an easy to remember number for the Pure Warmline because remember, again, we think much of the success of 988 is just because it's finally an easy number that anybody can find. So we worked hard. We didn't have Congress giving us a 3-digit number, but we worked really hard here to have an easily recognizable number. For us, that's 855 Peers NC. There is a formal MOU between 988 and the Pure Warmline, the Promise Resource Network. There are weekly collaboration meetings between the agencies. I mentioned the collaboration. We try to have uniform data collection across both lines so we can publish that public-facing dashboard that looks at data in the same way. And again, there's just so much collaboration between trends that they're seeing, joint trainings, and again, I'm not there. You will have wonderful folks. I'm delighted that we've got Kayla and Noah from both lines here today to actually talk about that collaboration. But I can do nothing but commend them for the help they're giving to citizens here in North Carolina, but also the way that they are working collaboratively together. And I think I maybe have one more slide. So that's our Pure Warmline dashboard again. And oh, this is just some information. This is our average age of callers. We have a huge satisfaction rate. We have a lot of people actually answer the satisfaction survey. We've had almost 80, we've probably exceeded 80,000 callers at this point. So again, tremendous uptake of this line. And then the next slide is just the last thing I wanted to say about our crisis system. I have mentioned, this is just data you can have about referrals, where referrals are going to off the peer line. But the last thing I want to show, and I'm just keeping my eye on the time, y'all. I don't mean to shortchange slides, but the last slide is actually about our campaign. So I've mentioned our 988 campaign and our Pure Warmline campaign. You all have them. If you can see Brittany right now, like this is just our new, this is our new Zoom background, and that was based on of our historically Black colleges and university campaign specifically. So that's the color scheme for that. But we've had so many campaigns. We'll have more campaigns for the Pure Warmline. But we've, across the entire crisis system, we've learned a lot from other states. And we actually worked with a marketing company to have our website be a centralized place of information. So we've actually worked to have our website be, when people Google search for services, it actually takes them to our website, which is really cool. You can obviously connect to 988. All of our pages heavily advertise 988. You can start a chat. You can start a video chat if you need deaf and hard of hearing supports. But we also have things like easy searchable maps for our community crisis centers, which is what we call our facility-based crisis, our longer-term facilities, and our urgent cares. So we've done a lot just to heavily advertise our crisis system and make sure that when people do look for resources, they can actually find them. Okay, so I will stop there because I know that we've got wonderful experts on here that I would love for you to hear.
Thank you so much, Kelly. Stick around because there's a ton of engagement in the chat around what you just spoke about. So I'm having a feeling that if we have some time, we'll be able to raise some questions there. But people are just really excited about the work that you're doing, you and your team are doing, and talked a lot about the way you're using data and collaboration. So congratulations on that. Thank you so much for walking us through. I'm now going to call up for our roundtable. We have Kayla Holder, who's a crisis counselor with Real Crisis Intervention, and we also have Noah Swab, who's the Chief Operating Officer for Promise Resource Network. Kayla, I believe I'm turning it to you first for your reflections on what you just heard.
Yes, and from looking at the chat as well, a lot of people actually spoke to my thoughts and what I plan to discuss, but it is a large need for people who are not necessarily in crisis, but seeking that support, as Kelly said before, support, connection, things that a peer could offer, a peer support specialist. So NOAA and the Promise Resource Network, it has been pivotal in providing that support for some of our callers that were able to either transfer or provide them the number, of course, if they accept that resource. Um, and I did just print off this. We have these within each of our cubicles. Well, you may not be able to see, but this just is the basic standard and what we follow for protocol for doing the transfer to the warm line. So we have these in each of our cubicles, and that's how important that peer line is for us because we rely on that when getting the calls, assessing callers, and from there seeing they may not be at imminent risk of suicide. It's not a crisis. Oftentimes we do receive calls where callers are like, I don't want to take up the resource of crisis, for someone at risk of suicide, but is there somewhere I can talk? And so that peer warm line comes in very much in handy. When needing an alternative resource that they're asking for. And that just shows you how important it is for us, that paper that I just showed, because we want to make sure all of our crisis counselors are aware of how and where to transfer those calls to when needed. Say if like someone is not in crisis. And it also is pivotal for us as well because it allows our lines to stay open. So we are able to get to as many individuals and reach as many people to assess and make sure large numbers of individuals can be safe from suicide. So Promise Resource Network has definitely been beneficial for us in helping us, especially with call volumes.
That's great. Thank you. It's great to hear how both the staff, but also people who are using the resource are thinking about, when to call for peer support, when to call for crisis support, and how integrating those two really helps to um, support people where they're at and make sure that people have the type and level of response that they need. So thank you so much for your reflections and for your work as well, Kayla.
Thank you.
Now I'm going to pass to you, Noah, for your reflections on what you just heard.
Thank you. So I think that, especially a lot of it got hit on already in some of the chat and excuse me, all the kind words that Kelly said about PRN and the warm line and our team. You know, I think when it comes to the warm line, it's definitely an addition to the continuum and it gives an option that a lot of folks may not have had before. Like when I go back to the beginning and early of my recovery, my daily norm, and looking back now, a lot of times I was in crisis and didn't even realize I was in crisis. And personally, I was not someone who was going to be receptive to hear that or get support from anyone that, like any person or an agency that truly didn't have that like authentic shared experience. And I needed someone to sit with me through the distress. With someone who had those shared experiences when I was, lonely, isolated, and genuinely terrified, because it builds a lot of skepticism and anger. And so having someone to build that credibility and that relationship and the credibility um, for someone who can listen and hear me and have that authentic understanding of what I might be feeling, because at some point they have been there themselves, and additionally provide a credible source of hope. I hope I can hear, I can see someone who has that shared experience and has made it on the other side. Is really it was a reminder in that moment that it's temporary and not permanent, and it gives you that hope. And you have to hear that from someone who like has been there and in it. And in my time, I started with PRN on the warm line, and in my time, I've taken thousands of calls, and that's a lot of what we hear from our callers is that they want someone that's had that experience. That I often talk about the peer warm line because I've been doing peer for quite a while now, but it's like that most authentic type of peer support because there's nothing. I mean, it's just you and the caller on the phone. There's nothing else there. That's it. And so you're really able to just sit with that person no matter where they're at in their journey. And in that isolated moment, whether it's anger, loneliness, grief, and sometimes happiness. Sometimes we get those calls where folks are just they're happy, and they just want somebody to tell. So we always want to be we really want to be a diversion from crisis services and incarceration whenever it's possible, and developing those relationships with people. I think Kelly talked about in that in her presentation of us really focusing on that relationship and that connection around that shared experience so that we can support folks wherever they're at and ready. And so lastly, just that shared experience is something that can't be replicated, and it has to be authentic. And I really want to give kudos to Kelly and NCDHHS and Real Crisis, the NC 988, because they recognize that very early on, and they champion not just a peer warm line, but a peer warm line operated by a peer run org. And that has really been truly key to our success, and I can't emphasize how important that element has been, and the collaboration and partnership that we've been able to develop, but independently with each other. And I really think that's been part of the success, because we're able to truly operate as a peer warm line. 988 is able to truly operate as a crisis service. And in our experience, in my experience, company's experience, this has been a key element of our positive impact and on our lines collectively and on the continuum as a whole.
Thank you so much, Noah. Thanks for reflecting on your own experience. What you said about the Pure Warm Line being a credible source of hope, and being able to see and hear someone who had been where you are and able to talk about their own experience, that's a powerful anchor and a powerful source of healing and hope. That I think that really hit me. I also noticed someone in the chat, and this struck me as well, is one of the last things you said, that this Pure Line operates so well because it's not just a Pure Line, but it's a Pure Line operated by a peer organization, a peer run and led organization. Could you say a little bit more about that? I think that's a crucial point that you touched on.
So, I mean, I think that when you're a peer warm line and it's a peer operated agency, we're able to operate in that manner. We don't have a clinical arm, and so we are truly able. We're focused on peer, and there's going to be a rub at times. There's absolutely going to be a rub between like the peer and the clinical side. And we're able to have that. We're able that those weekly collaborations. The relationship that we have. We're able to have those conversations, but there's no rub with 988's internal. They're able to completely do what they need to do without worrying about stepping on anything when it comes to peer. And peer is able to do exactly what peer needs to do when it comes to doing peer, and not worrying about having to step on internally. And we're able to just operate and really, we lean into that. We lean into that. We have those conversations. And I think that's what's made our partnership so strong. And if we have any issues, or not really issues, I wouldn't say issues, that's not the right word, but if we have any topics we need to collaborate on, then it's a phone call, it's a text message, an email, anytime, any night, and it's solved quickly so that we can support folks.
That's fantastic. So both organizations can really lean into who they are and what their strengths are. And then because you have a strong relationship with each other, you can navigate the moments where there might be some disagreements or differences, so that's thank you so much. Thanks for your work, Noah. Thanks for your reflections with us today. Really appreciate it. And there's also, both for you and Kayla, there's a ton of support in the chat as well. So definitely take a look at that. I actually did just see a question come up in the chat. We do, and I'm not sure if Kelly, you would be the best person to answer, I imagine. But if the warm line has a crisis call, do you do a warm transfer to 988? Does the transfer go in that direction as well?
So I can take that. Oh, sorry.
No, go for it. Go for it, please.
Hi, everybody. My name is Brittany Jones. I'm the crisis services team lead with the division. So I'm under Kelly's team. So yes, if there is someone that calls an active crisis to the Peer Warm Line, Noah and his team will be able to transfer over to the 988 call center. So the warm transfers go back, vice versa. So if Kayla and her team feel like there's someone that's calling the line that maybe needs some additional support, and ongoing additional support, then they will be able to give that information and warm transfer to Noah's team and vice versa.
Thanks so much, Brittany.
Mhm.
There's a couple other things that were called on the chat. I think we have a few minutes, so I don't know if you're the best person to answer, but if you want to stick around, if not, we can pass it to someone else. But one of the other things that people noticed in the chat was the fact that uh, the peer line didn't reduce calls to the 988, that it did seem like they really complement each other. You didn't see a reduction in 988 calls when the peer line came on. So just wondering if you could reflect on that a little bit more, if you've thought about why that might be the case, or um, because for some folks that was an unexpected uh, result.
These are just Kelly's thoughts. I'd welcome other folks weighing in, but I didn't expect any reduction whatsoever. Um, I um, I think the lines are different, and I think what we deal with the 988 line is actually probably what a lot of people experience, right? So there's still, even though 988 is anonymous and free, there's still a lot of anxiety about calling. People are still worried about law enforcement being called, someone showing up to their home unannounced. And that's not 988's fault. It's just obviously the decades long legacy of what we do to folks with mental health issues. So I do think 988 is unique in that it's getting folks who do have perhaps maybe have had bad experiences or who are just new to the system to call. And we're not even beginning to touch the number of people who need support. And we try to call it support. We're not trying to co-opt the line for anything more than it is, but we do emphasize its lifeline properties. And we just try to let folks know it's a place just to get help. It's anonymous and you're okay. But I do think a lot of times people call the peer line just for, you know, I just think it's a culture that we're trying to cultivate here in North Carolina. I think it is incredibly comforting to talk to someone who literally knows what it's like, not just to navigate maybe a serious mental illness or maybe your own emotional crisis, and be rejected by that or harmed by that or harmed by a treatment system for that. So um, I just think there are places. They're both places. I don't know what others thought. I did not expect to dip at all, and I expect more and more people just to keep on calling. Yeah, I could pontificate on that for a while, but we're doing everything we can to get more people to call the lines because they are proving just to be, especially 988's proven to be a gateway. It's literally proving to be a gateway to service delivery if that's what folks want. But sorry, that was just me rambling. I would love thoughts from others.
That's fantastic. I think that seemed to resonate with folks in the chat. It certainly makes a ton of sense to me. I think what you're really highlighting is that there's a different kind of support, which we heard from Noah, which that peers are able to provide, that can be significantly, that for some people is it's really important to be able to connect with someone who's had their own experience, which is like barely needs to be said. Like we know that, but too often that's not available, and too often people are coming into contact with systems that can be very stigmatizing. And so being able to talk to someone who has had your experience, has gone through what you are going through, can be really it can be affirming and healing. And that, of course, though, doesn't at all diminish the need for more like for clinical services or 988 services. Both of those have their place. So they really they don't diminish one another, they feed on one another, and they really help people connect where they need to connect. So it makes a ton of sense to me. I think we have literally 2 minutes, and I think pontificating is great in this space. So there was one other question that really calls for pontificating. There's just to summarize it, is this the time and there a need for a national Warmline network? Some folks have been advocating for a while. And what's your experience tell you in North Carolina about the need for a national Warmline network? You, Kelly, or you, Brittany, or anyone on your team?
No lie, I was just typing in the chat. I don't know if Noah can speak to the fact that I don't know how much it happens, but no, I've heard that folks from other states are calling the Peer Warmline. So it feels like it's a real unique thing and people are hungry for it. And so you guys are getting calls from other states.
We do get a lot of calls from other states. We actually very unintentionally, when the Warmline went live, well, re-live again during the pandemic, went nationwide. Very unintentionally. And the demand was very overwhelming, and we had to scale back to North Carolina and Mecklenburg, and then expand back out to state. So we do get a lot of calls from other states, and we definitely try to support folks in connecting with their local state warm lines if they have one. A lot of them are broken, some have state warm lines in my experience, and then they're broken down by region or counties, and connecting, but there is a lot of restrictions based on your location and area of who you can call and when, but we do get a lot of calls from out of state.
Glad, yeah, that does seem to speak to the real need and desire for this as a resource that's more accessible. Thank you so much to all of you for speaking. Thank you also to Kayla, but also and to all the work that you all are doing in North Carolina. I really appreciate it. I appreciate your time with us today.
Thanks for having us.
Okay, next up, we have the Nashville update with Justin Vogt.
Hey, thanks, Aisha. Hey, good afternoon, good morning, everybody. My name is Justin Volpe. I'm a senior peer support coordinator here at Nashville, person in long-term recovery with lived experience. It's good to see everybody. Joining from Miami, Florida, a little rainy today. I don't know how the weather is around your neck of the woods. We talked about, states highlighted. We have experts from 37 different states highlighted on Crisis Jam. Still missing a couple states. If you're one of these states that is not colored in with a picture, reach out. If you have a program you want to highlight, love to see it. So, looking forward to it, reaching out. Thank you. Today I'm going to talk about our work at Nashville, which we dubbed the TTI Award. It's a SAMHSA award that Nashville has had for states and territories since 2007. We've funded over 362 projects. Every state and territory except for California has had an award. Was blessed to, work with so many projects with Nashville the last 4 years and really get a national lens of what's going on, what states need, what territories need, and working with people in direct service and managing those things. We thank SAMHSA for this award, and today we're going to highlight Utah's TTI award. We started in 2021. Their first award was on forensic support specialist. They actually, took a curriculum from another state and made it work for them, and that works. Don't reinvent the wheel. If it's not broke, don't fix it. We can take things and adapt them to our states and communities. They started a forensic peer curriculum. Go ahead, next slide, please. And, as the outcome of that award in 2021, they saw great value within law enforcement, courts, correctional officers, and paved the way to expanding the project. The biggest restriction they had was, hiring people with criminal records. And yes, they found a way around it. A local corrections agency was able to waive restrictions and hire someone directly. And that's what it takes when you look somebody in the eye, you shake their hand, and you feel them out, and you understand what a person's value is, not looking at an old rap sheet. And there's really power in that, and that's my story as well. Um, Go ahead, jump ahead to the next slide. Fast forward 4 years later, they expanded on that and put these forensic peer specialists to work in the community, getting people out of prison, out of incarceration, and getting them connected with supportive employment. I mean, this is what they want, right? They want successful reintegration. What better ways to put peers as liaisons between these teams and really do the work? And the community there. I got to visit it 2 weeks ago. Which was an honor because I don't, our Nashville team doesn't get to see a lot of the work in person. But I was there for a peer conference and got to visit the jail and see that this forensic curriculum expanded to the prison. If you want to go to the next slide. Um, they have peer support as a job within the prison, as they do other prisons across the country now. Ohio, Georgia, I know to name a few. If I've misspoken, I'm sure there's more doing it right now. Was with the men's general population and the women's general population. gives people sense of purpose, something to do. The vibe was so high there, guys. You would not think this is a prison. Everybody got along so well between the officers and the inmates. Go ahead to the next slide. They they had instances of violence and stabbings decreased by more than 50%. I mean, that was incredible. And it's new within the prisons. It's only been going on for 12 or 15 months, I believe. And more people want to take it. More people want this curriculum. They're talking about expanding it to people on life and death row. One of the gentlemen in this picture has taken the curriculum and is looking to do it. So it was really great to see people want to do this, it work, and the environment just really blossom. Go ahead to the next slide. And this is a gentleman I met at the conference. He had done 2 or 3 years in prison, just got out 3 weeks before I took this picture with him, and he was given a job at a county jail diversion program as a county employee. He still had an ankle monitor under his pants. That's what it looks like, right? I mean, that's incredible. How far have we come that one day, people with criminal records couldn't get jobs, and now they're given jobs for local government offices, state office, counties to give back and have purpose. And that's successful to me. And it was an amazing experience. Thank Nashville, thank the TTI team, and I'll kick it back to you, Aisha.
Justin, thank you so much. I mean, you're completely correct that or I completely agree with you that it's amazing to see that we've come so far where folks who have been recently released from prison can go back and provide support to their peers. That's really, I think 10 years ago would have been shocking to see. So just thank you so much for raising that and for highlighting that. I appreciate it. Next up, we're going to do a state spotlight on North Carolina with Robert Robertson, CEO of Alliance. Robert.
Hi, thank you. It's good to be with you all. And Justin, it was great hearing about that program. Sounds like some really awesome work being done. Again, my name is Rob Robinson. I'm the CEO with Alliance Health. We are a local management entity / managed care organization in North Carolina. We serve folks with severe mental health, severe substance use disorders, and people with intellectual and developmental disabilities. And we are responsible for whole person care. We serve the central part of the state, primarily the urban parts of the state. We are one of 4 LMEMCOs. We serve the Raleigh Triangle area, Durham, Cumberland County or Fayetteville, Orange County, and Raleigh. And then we also serve Mecklenburg County, which is Charlotte. So we operate very similar, if you're familiar with the terms, special needs plan, which is a Medicare plan, SNP, we operate in that manner. So bottom line is we're responsible for those with the greatest needs in our communities, those with Medicaid and those who are uninsured. So it's really good to be with you. I got to thank Karen for helping me get connected. Few issues, but Karen helped me out, so I'm grateful to her. So I was here to talk about the crisis system in North Carolina. We are undergoing some changes in North Carolina. We need more changes, and I'm sorry I missed Kelly's presentation today. So hopefully my work or my presentation will align with what she did. She's been a very good partner for us in recognizing changes and helping to move forward. So before I get into that, and I've got 3 slides, and I know I only got less than 5 minutes, so I'm going to run through these pretty quickly. But I do think it's important to give a little background as context. So the LME MCOs, we've evolved over the past 50, 60 years. We started off as community mental health centers. We moved to transition to serve the people, become a managed care organization for those who are uninsured. We operated a behavioral health carve-out for several years. And this past year, we became a whole person health plan responsible for the population that I talked to. We've always been responsible for the crisis system. For many years, we were the only game in town. There weren't other managed care organizations. We were responsible for this establishment of the crisis system. Over the past couple of years, the state has moved under Medicaid transformation, and there were more plans added to the system, but the crisis system and how it was designed and managed did not change. I could spend hours on Medicaid transformation, but the bottom line is there are more health plans working with us to serve the Medicaid population. So the system didn't change. We've also seen, I'm sure you've all seen, the demand for crisis services have increased. And for the purpose of this presentation, I'll be talking about facility-based crisis, behavioral health urgent care, BHOCs, and mobile crisis. The last part I want to talk about how we have funded the system for the past several years is through the firehouse model. And if you're not familiar with the firehouse model, how this works, we ask the crisis providers that I mentioned, send us a budget, right? What it's going to cost for you to operate. We ask the providers to bill as much as they can, all payers, including us. And then to meet the needs within your budget, we will stroke you a check to pay that out on a monthly basis, right? So if the budget's $100, they bill $80, we'll pay for $20. We have done this intentionally because we don't want our crisis providers to have to worry about volume, making payroll. We're saying we want you to focus specifically on quality services for the members. Bill as much as you possibly can, and then we'll make you whole. Next slide, please. All right, with the introduction of Medicaid transformation in 5 other health plans, there's some challenges that we're working with the state and my other LME MCO colleagues to overcome. One is the system didn't change. LME MCOs, and particularly for us, our counties are the only groups that are investing in crisis services. The state has recently also been a good partner and have begun developing services as well, right? So we're investing, and for us, it's $30 to $50 million over the past 5 or 6 years in the crisis system. So we're building it, but everybody is using it, right? Which normally I would be okay with, except for the third part, the dark blue, which I'll get to in a second. Well, let me just go there now. The payment and operations. The other payers have not consistently contract or paid for the services that are used by their members, right? They've contracted and paid a substantially lower rate to cover the cost. The other part is the oversight. Under the old model, LME MCOs were the only ones responsible. Now there's multiple health plans responsible, which puts an administrative burden on our crisis system to be audited by multiple partners. They have to bill multiple partners for care, and it's made it more complex. So the result of this is that we've been the default. Alliance, my agency, and the other LME MCOs have been the default to make financially whole. We stroke out checks for about 25, I think we're as high as $30 million a year to pay for services that are for members that aren't ours. So we've gone to the state, say you've got to make a change. And next and last slide. And here is our recommendations. We brought in a group, HMA, who we've been extremely pleased with, to work with us to make some recommendations, and they look statewide. And there was 3 states in particular they looked to, and I got to remember, Massachusetts, state of Washington, and Arizona as models that are similar to us, but are more financially solvent than our system. So the 4 recommendations are: have a single entity responsible for the oversight of the crisis system, not 9 health plans like we have in North Carolina, but the 4 LME MCOs. The 4 LME MCOs are responsible for payments. We have for the uninsured, so we get state dollars, grant money, anything else, run it through us, and then we'll run it through the provider, and then make all Medicaid health plans responsible for paying for their members using a standardized Medicaid rate. This has gotten a little bit better. We've been trying to work with our standard plan or other health plan partners to pay. And then lastly, each commercial plan, this has probably been the big barrier, who aren't necessarily familiar with facility-based crisis, BHUC, et cetera, they need to pay for their services. And so those are our recommendations that we're working with the state on. We're not quite there with the state, but we'll continue to do it. I hope this was helpful and provided the information that we're looking for, but this is what's happening in North Carolina. Back to you, Aisha.
Thank you so much, Rob. Thanks for being with us and for giving that great overview. Appreciate it. Next, I'm going to call up Sarah Corcoran for our federal update. Sarah.
Thank you, Aisha. So here is our update for this last full week of June. Very hot week for those of us in DC and a lot of the country. So on the FY26 appropriations process, as part of that process on the Hill, before the House Energy and Commerce Committee yesterday, HHS Secretary Kennedy appeared to defend and answer questions associated with the HHS budget request for FY26. 988 did not specifically come up during those questions, but there were a handful of questions that touched on funding and staffing issues around mental health, substance use, and SAMHSA that were asked during the course of that hearing. So that happened yesterday. I believe there are a couple committees left that Secretary Kennedy has not appeared before, but that's kind of all part of the general appropriations process before the committees release bill text and have markups on both the House and Senate side. And as a reminder, FY26 begins October 1st of 2025. On the reconciliation update, I know we've covered that on previous jams of kind of where we were in that process. As of now, the bill has passed the House and is in the Senate. We are waiting on the Senate to see timelines of releasing their final text to vote on and go through the amendment process. At that point, it would have to be conferenced or worked out between the House and Senate, since those are different versions. But they do have an ambitious deadline of July 4th to get that done. But as of now, we are waiting. And the Senate is working through the Byrd rule process with the parliamentarian, not to go too into the procedural weeds, but basically a process where challenges can be raised against the provisions in the bill to test whether or not they have an effect on the federal budget. And if they do not, then they would have to remove those provisions from the bill, which would slow down the process. So as of now, it could be released as soon as today, but we're waiting to see what is happening. And then finally, I will share in the chat some links. And moving forward, I'll include the links on the slide as well. But Reps Smith, Democrat of Washington, Adam Smith, and Fitzpatrick, Republican of Pennsylvania, reintroduced the 911 Community Crisis Responders Act that was introduced in previous Congresses, bipartisan bill on the House side, and it would create a grant program for states, tribes, and localities to create and expand mobile crisis response programs. Specifically in the bill, it does call for coordination between 911 response and 988 response. So that's a bill that I will share the link in the chat too. If there are any questions, happy to answer them, but I will turn them back to you, Aisha. Thank you.
Thank you so much, Sarah. Really appreciate the update. Okay, and with that brings us to the end of our episode. Thank you to all of our speakers. Thank you to all of you for being here. Next week, we have a fireside chat with Dr. Richard McKeon, fireside chat with the grandfather of 988 and crisis care. Definitely tune in for that. Richard's always great to hear from and has a wealth of wisdom. And then after that, in 2 weeks, we have a day in the life of crisis care part 3, a safe place for a safe place for help. So the first one was focused on the day in life was focused on place to call. Then the second one was focused on someone to come to, and now a safe place to go. So thank you so much for being here with us today, and we look forward to seeing you here next Wednesday. Have a good rest of your day and rest of your week.